Hi, everyone, and welcome back to the Evidence-Based Birth podcast. Today, we are going to wrap up our pain management series. Since January of 2018, we've covered 20 topics in the series, plus we did an overview at the beginning all about pain management. So pain seems to be the number one thing that people I talk to, young people, are worried about when they think about giving birth. Pain management is also a huge reason for the healthcare system's involvement in birth. We started back with EBB podcast number 8 with that overview of pain management. And in that podcast, we talked about how there are two major ways of viewing pain during labor. One way of viewing labor pain is that it's unnecessary and that the pain-relieving benefits of medications are always worth their potential risks or side effects. This is called the pain relief perspective, and it's very common in today's societies. In fact, most doctors and nurses are trained to assess people's pain and try to eliminate it if at all possible. Another way of viewing pain is the working with pain or coping with pain perspective. This perspective was most common historically out of necessity, but it's still used by a lot of people today. According to this perspective, labor pain serves a purpose, and it's an important part of the normal physiology of labor. For example, the sensations from contractions might compel the laboring person to move around or may change positions, and that would help the progress of labor. Another perspective, and one we did not mention in the overview, but was pointed out to us later, is that some people believe that you can have a painless birth without medication. And we talk more about that in episode 18. Now, people that follow the working with pain or coping with pain approach to childbirth do make an important distinction between the concepts of pain and suffering. It is possible to have suffering without pain and pain without suffering, or to have both occur together. For example, people with an epidural could have no pain, but they could still suffer from emotional distress or anxiety or feeling helpless or feeling left alone. On the other hand, it's possible for someone to be coping well with labor and not interpret their pain as suffering, just as athletes sometimes experience painful sensations from their efforts, but they don't interpret it as suffering. Of course, it's also possible to have both pain and suffering occur at the same time. But in our series, we've covered a variety of tools that are available, both pharmacologic, drug, and non-pharmacologic, non-drug, that can be used to help manage both pain and prevent and alleviate suffering. So in this wrap-up podcast, we're going to summarize the pharmacologic, the drug, and the non-pharmacologic or non-drug methods of pain management strategies. So let's start first with pharmacologic methods, which we covered in detail in the Evidence-Based Birth podcast episodes 9, 12, 13, 14, and 15. The pharmacologic methods of pain relief that we've covered include the epidural, spinal, and combined spinal epidural, often known together or lumped together as regional analgesia. We've also covered injectable opioids, which can be given as a shot in the muscle or through an IV, and nitrous oxide. Of all the pharmacologic methods of pain relief, regional analgesia, again, which consists of epidurals, spinals, and combined spinal epidurals, is the most effective form of pain relief and probably the most common method in the United States where I live, but it also carries a number of potential side effects for mothers and babies. Known side effects include lower maternal blood pressure, a longer pushing phase, a higher risk of needing a forceps or vacuum delivery, a greater risk of needing Pitocin, and a higher risk of the baby having abnormal fetal heart tones. It also carries other side effects like itchy skin, nausea, and about a 1 in 100 chance of spinal headache. Also, professional associations estimate that about 1 in 8 or 1 in 10 women will not receive effective pain relief for an epidural, so there is also a chance that the epidural might not work. However, epidurals carry much fewer side effects for babies than another drug option known as injectable opioids. Injectable opioids are probably the least safe medication option for babies, and they're also not as effective as epidurals in terms of relieving mother's pain. Injectable opioids given as a shot in the muscle or through an IV can also cause maternal nausea, vomiting, and drowsiness. However, they can be an option for mothers who desire drugs for pain relief, but either prefer or need an alternative to an epidural or spinal. In addition, we covered nitrous oxide gas. Inhaling a mix of 50% nitrous is less effective for pain relief than an epidural, but it has not been shown to increase bad outcomes for mother or baby, and it only has some minor side effects. Some of these side effects include things like a sense of detachment, sleepiness, or claustrophobia. In contrast, injectable opioids have the greatest potential for bad side effects, and the effectiveness of injectable opioids appears to be about similar to nitrous oxide. Nitrous is not yet commonly used in the United States, although it's extremely common in some countries. And many people report high satisfaction levels with nitrous, despite the fact that it gives incomplete pain relief. Researchers and clinicians say that it may help more with coping than actually lowering pain levels. More and more mothers that I know are looking for places to give birth that offer nitrous, and I keep hearing from more and more nurses and midwives telling me that their hospitals are trying to decide if they should start offering this option. So those are the drug methods that we covered for pain management during labor. So now let's turn to non-pharmacologic methods. The evidence on the effectiveness of non-drug methods of pain relief for labor is limited, but findings are promising that they offer some benefits, especially in early labor and especially when the non-drug methods are combined. Since non-drug methods of pain relief are simple, inexpensive, and free of side effects most of the time, they should be made more widely available for mothers to use before they have pain medications, in place of, if that's what the mother wants, or even used in addition to drugs for pain relief. I'm going to go through each of these non-drug methods that we covered in alphabetical order. And I'm also going to note the method through which these non-drug methods work. If you go back to the overview on pain management that we did in episode 8, we talked about the 3 main pathways or methods through which non-drug strategies work to help manage pain. One is called the central nervous system control mechanism. This mechanism works in your brain to change how your brain perceives the sensations coming to it. Another method is called the gate control theory. The easiest way to explain this method is to, if you hurt your thumb, the first thing you're going to do is grab onto your thumb with your other hand. By flooding your nerves with non-painful stimuli, such as that coming from your other hand grabbing on, it interrupts the transmission of the pain signals up to the brain. And the theory is that your nervous system can only handle so many messages flooding through at once. So if you flood the nerves with non-painful stimuli, sometimes you can't perceive the painful stimuli as much. And then the third mechanism is the diffuse noxious inhibitory control mechanism. With this method, you actually apply a painful stimuli, that's the word noxious, and you intentionally create pain in order to stimulate the brain to release endorphins, which are your own natural supply of morphine-like hormones. That's often abbreviated the DNIC method, diffuse noxious inhibitory control. So without further ado, here are the non-drug methods in alphabetical order. Acupuncture and acupressure are thought to work through the DNIC method. In randomized trials, people randomly assigned to acupuncture reported less intense pain, higher satisfaction levels, and they were less likely to need pain medication. However, one of the drawbacks of acupuncture is that it requires a licensed provider to be on site. And although this is available, for example, in some European countries, it's not available in the United States. At least I've never heard of anybody providing licensed acupuncturists in the hospital setting. In contrast, acupressure simply requires familiarity with specific points on the body and when to put pressure on them using your hand or fingers. When people are randomly assigned to acupressure, they've reported less intense pain and lower levels of anxiety, as well as other benefits such as shorter labors. Although more high-quality research is needed, both acupuncture and acupressure do appear to be more effective than placebo and more effective than no treatment. You can learn more about acupuncture and acupressure in EBB episode 25. Aromatherapy probably works through the central nervous system control method. Studies have found lower levels of pain and anxiety linked to orange, rose, geranium, pure salvia officinalis. And as a side note, when I said salvia officinalis, I did mean salvia officinalis, not clary sage, and lavender. Peppermint was especially helpful at reducing nausea and vomiting. In one large study, more than 50% of mothers rated aromatherapy as helpful for coping with labor. In general, aromatherapy may help ease anxiety, promote relaxation, and promote greater satisfaction with childbirth. At this point, we don't have any research evidence of harm to mothers and babies with the essential oils that have been studied for use in labor. However, essential oils do have the potential to cause allergic reactions and skin irritation. You can learn more about aromatherapy in episode 26. Next, I want to talk about birth environment. This probably works through the central nervous system control method. To learn more about birth environment, I highly recommend that you listen to our podcast on painless birth, which was episode 18. In that podcast, we talked about how your state of mind influences how you perceive pain. For example, you could have a mindset of mindful acceptance, in which the sensations you feel would feel less painful, versus feeling distracted and distraught or upset, which would lead to a higher perceived pain level. Environmental stressors are also linked to increased reports of pain. Things that mothers have cited in research studies as increasing their pain levels include having a crowded room during the delivery, noise, and restrictions on movement and restrictions on eating and drinking. The info in the Painless Birth podcast has a lot of important implications for labor and delivery staff because they have a lot of control over how stressful or non-stressful the environment is for birthing parents. Next, childbirth education probably works through the CNSC method, or the central nervous system control method. We don't have enough research right now on the effects of childbirth education. And one of the reasons for that is because all of the studies have used very different methods of childbirth education. However, an important study by Levet et al. Came out in 2016 showing that a childbirth education course that incorporates 6 complementary medicine techniques led to a lower rate of epidural use, a lower cesarean rate, a shorter second stage on average, and less and fewer cases of perineal trauma. We talk in detail about that study in episode 28, all about the research on childbirth education. It's thought that acquiring knowledge and skills before birth may help lower fear and anxiety, and mothers and their partners may learn useful coping strategies. However, the content and the quality of childbirth classes is variable, meaning that you can have very high quality childbirth classes, such as the comprehensive class in the Levet study, that led to improved outcomes, but you can also have childbirth classes that do not improve outcomes, or the quality of the childbirth class is not as good. The next pain management method I want to talk about is conscious breathing. This probably works through the central nervous system control method. Evidence does not support the use of conscious breathing by itself, so breathing alone does not relieve pain. At least we don't have evidence that it does. However, several randomized controlled trials have found lower pain scores when breathing is combined with other non-drug approaches, such as childbirth education, continuous labor support from a doula or a nurse, massage, position changes, and muscle relaxation. The cool thing about breathing techniques, or focusing consciously on your breathing, is that it's simple, free, non-invasive, and can be used alongside other pain relief methods. Also, learning slow, deep, controlled, conscious breathing techniques can offer long-lasting benefits for relaxation outside the area of childbirth. You can listen more about the research on breathing in episode 38. Next, let's talk about doula support, which possibly works through the central nervous system control method. Randomized trials have consistently found that continuous labor support is linked to a lower risk of cesarean, a higher chance that you'll have a normal vaginal birth, a decrease in the risk of being dissatisfied with your birth experience, a decrease in the use of pain medications, shorter labors, and lower pain levels during labor. Doulas can support mothers who are using a variety of both drug and non-drug pain management methods. Doulas provide physical support, emotional support, childbirth preparation, and some provide advocacy support. Overall, doulas seem to be a risk-free, evidence-based option, and we talk more about the evidence on the use of doulas for pain management in episode 21. Next, hypnosis, which probably works through the central nervous system control method. In randomized trials, people randomly assigned to hypnosis are less likely to use pain medication than those who receive a control treatment. Researchers have also found that hypnosis may be especially beneficial when it's combined with water immersion. There have been no reports of adverse outcomes or bad outcomes with the use of hypnosis. However, one potential side effect is that sometimes providers and healthcare staff might misinterpret the client's relaxed state and think that they're in early labor when they might be much further along in labor. We talk more about the evidence on hypnosis and two of the more popular hypnosis programs in episode 31. Massage works through both the gate control theory and the diffuse noxious inhibitory control method. In randomized trials, people assigned to receive massage in the first stage of labor, so before the pushing phase, have lower pain scores compared to usual care. Randomized trials have also linked massage to lower levels of anxiety, an increased sense of control, and increased maternal satisfaction with childbirth. Outside of childbirth, massage has been recognized for a long time as safe and effective in the hospital setting. We covered massage in detail in episode 34. Music probably works through the central nervous system control method. Randomized controlled trials have found that people report lower pain intensity when listening to music in early labor. However, they found no clear benefits during active labor. Music may also help lower anxiety levels during the transition phase of labor. And in one study, 88% of people who gave birth without pain medications reported that having music or listening to music was at least partially effective at providing pain relief. And we covered the research on music in detail in episode 35. Positioning and movement are probably one of the more important methods of non-drug pain management strategies that should be used with everyone regardless of whether or not they're having medications. Positions and movement probably work through the gate control method. There's actually a lot of research on positioning and movement, and researchers have consistently found that when people are randomly assigned to be upright and moving around instead of lying in bed during the first stage of labor, that the people who are upright and moving have shorter labors, are less likely to request an epidural, and less likely to have a cesarean. Also, 3 of the 4 randomized trials that have measured pain have found lower pain levels in people who are using upright birthing positions, so when the baby's actually coming out. So positioning and movement are not only important for the first stage of labor, but for the second stage of labor, when you're pushing, they can have a really significant impact on pain levels to be upright. However, some birth settings might not support mobility during labor. For example, if you're in a birth setting that requires continuous electronic fetal monitoring, or if you have a medical condition that puts you at higher risk, so you need to be on the monitor continuously. Also, some care providers may not be willing to assist at an upright birth, and they may require you to be in the bed or on your back. We talk more about these problems with the lack of availability with upright positioning during labor and birth, as well as the evidence on positions and movement in episode 16, where we focused on mainly the first stage of labor with positioning, and episode 17, where we specifically focus on the evidence on upright birth. You can also read more about upright birth positions and our signature article available on the Evidence-Based Birth website. Just go to ebbirth.com/birthing positions. The rebozo probably works through the gate control method. There are no scientific studies on the effectiveness of the rebozo technique. And when I came out with the rebozo podcast, it was interesting to me how many people said that they'd never heard of the rebozo before. The rebozo has a long history of traditional use in Mexico, and its effectiveness so far is supported by midwives and women's experiences over many, many years. We do have one qualitative study that's an interview study that came out of Denmark that found that most people's experiences with using the rebozo during labor were positive. The rebozo may be especially helpful with relieving back pain if the baby is in a less than optimal position, so if the baby's in a posterior position. However, right now the rebozo is still not common in many birth settings. If you want to use one, you likely have to provide your own rebozo along with someone who is trained in using rebozo techniques, such as a doula or a midwife. And I didn't mention it earlier, but a rebozo is a long, beautiful woven shawl. And it's important to purchase authentic Mexican rebozos in order to avoid cultural appropriation. And we talk more about that and about the effectiveness and techniques of rebozo in episode 36. Relaxation techniques work through the central nervous system control method. In one randomized control trial, a relaxation intervention consisted of progressive muscle relaxation, conscious breathing, position changes, additional nursing support, and massage. And these researchers found that this combination that included relaxation lowered pain levels during early labor by an average of 1.25 points. So we do have some evidence that relaxation, when combined with other methods, can be effective in early labor. Right now, there's a lack of high-quality evidence, and because relaxation, such as guided imagery and progressive muscle relaxation, are typically combined with other non-drug comfort measures, we don't know specifically which relaxation technique works best. However, relaxation is considered safe and effective outside of the childbirth arena, and the benefits of learning relaxation techniques can be used both during the birth and for the rest of your life whenever you're in a stressful situation. We talk more about the evidence on relaxation in episode 37. Sterile water injections work through the DNIC method, the diffuse noxious inhibitory control method. And this consists of 4 small injections that are given in your lower back on either side of the spine. The injections can be very painful to receive, but what they do is then stimulate your brain to release endorphins, which are your natural morphine-like hormones. This can be especially helpful to relieve pain from back labor, which can be experienced by as many as 1 in 3 laboring women. Randomized trials have found a greater reduction in average pain scores with sterile water injections compared to saline placebo. And saline is used as the placebo because saline or salt water does not cause that same kind of pain that you get when you inject sterile water. In one study, nearly 90% of women who received sterile water injections reported that a pain-relieving effect compared to only 45% who had the placebo with saline injections. And although the injections can be very painful to receive, more women in the studies say that they would request sterile water injections again for a subsequent birth compared to those who received the placebo. We talk more about sterile water injections in episode 29. The TENS unit, or transcutaneous electrical nerve stimulation, works through the gate control and the DNIC method. A TENS unit is a small device in which you put little electrodes on your skin, typically on your lower back, but potentially in other places. And then the patient can control the electrical stimulation going to the skin. Randomized trials have found little difference in pain ratings when they compare TENS to placebo TENS. And a placebo TENS is typically either the machine that's hooked up but turned off and the patient doesn't know that it's turned off, or the machine is turned very low. So that would be the placebo. However, when TENS is applied to specific acupuncture points, people are less likely to rate their pain as severe. And more people assigned to TENS say that they would use it again versus those assigned to a placebo treatment. There was another recent randomized control trial that found that the use of TENS delays the use of pain medication. So people can go longer without pain medication if they're using the TENS. Another recent trial found no difference in pain scores between those who received TENS and those who received an injectable opioid, but obviously they found side effects with the injectable opioid. And so we cover TENS in more detail in episode 27. Finally, we're getting to the end of the alphabet. Water immersion works through the gate control method and is actually one of the most well-studied non-drug methods of pain control. So we have a lot of research on this method. And randomized controlled trials have found that water immersion lowers pain scores and lowers your need for pain medications. Water immersion may be especially helpful when it's combined with learning hypnosis. And overall, water immersion in a tub has found to be not as effective as regional analgesia, so it's not as effective at lowering pain levels as having an epidural, but water immersion is more effective than injectable opioids. Water immersion in a tub has also been shown to lower maternal anxiety and increase satisfaction with your ability to move around and have more privacy. Women say it creates a feeling of being in a protective bubble. Also, researchers have found that laboring in water poses no extra risks to mothers or babies. We talk about the evidence on laboring in water in episode 20. And if you want to learn more about the next level of pain management with water, and that's using it during the second stage or the pushing phase, we do cover the evidence on water birth in detail in episode 11. and in our signature article on Waterbirth, ebbirth.com/waterbirth. Finally, with all of our non-drug methods, I do want to talk about combining multiple methods. One of the biggest takeaways that we found is that it's important to combine multiple non-drug methods of pain relief. There was a meta-analysis published in 2014 by Chaillet et al., Chaillet. They looked at all of the non-drug methods of pain relief, and they found that people are best able to cope with labor when they use at least one method of pain relief that works through the central nervous system control method and combine that with another pain relieving mechanism using either the DNIC or gate control theory. So combinations of these pain relief strategies are more effective than just using one. They also talk in their article about how pharmacologic or drug methods of pain relief should be used in addition to non-drug pain relief as needed to avoid suffering. So they don't need to be used in all cases, but they definitely should be used as needed to avoid suffering. So the bottom line is that birth settings and providers and staff should provide a broad range of both drug and non-drug methods of pain relief. There are so many options out there, but often what I see when people are giving birth is they might only have access to a couple of options for pain management that are typically offered. And if they want to have more options and have the full range of options and this full toolbox of all of these tools at their disposal, they have to learn how to do them themselves and sometimes even bring them along, like bringing your own Rebozo or TENS unit, or making sure you have a midwife who knows how to do things like sterile water injections. In general, there are just a lot of barriers to providing the full range of comfort measures. So to help address these barriers, here at Evidence-Based Birth, I am developing a workshop specifically for labor and delivery nurses all about using comfort measures with their clients. And I am pilot testing that this coming Sunday. And we're going to be rolling it out in 2019 with all of our evidence-based birth instructors being able to provide that workshop in their communities. Also, I think it's important if you're pregnant and expecting a baby to prepare yourself by taking a childbirth class that teaches you multiple non-drug comfort measures that you can combine. Most non-drug comfort measures are free or cheap, non-invasive, easy to use, and carry mostly benefits with very few or no side effects. I'm a strong believer in non-drug comfort measures being used by everyone, whether or not you plan to also use medications for pain relief. So I'd encourage you to learn more about the options that sound interesting to you and to set yourself up with a support team that knows how to use those options with you. I hope you found this A to Z wrap-up helpful. We spent a tremendous amount of time on this pain management series, and I'm glad it's out there. We've got YouTube videos, blog articles, podcasts on all of these different pain management strategies. And my hope is that they'll be useful to all of you for years to come. If you ever want to see all of these pain management blog articles in one place, just go to the main Evidence-Based Birth website, click on blog, and then you can select pain management series, and that will filter just so you just see all of the pain management articles with the YouTube videos embedded and all of the references right there. Next week, we are going to shift gears and start interviewing people who are change makers in their community. So I'm excited to introduce you to some of your fellow listeners who are doing amazing things in their communities. Before we go, I do have one quick announcement, and that is that applications for the Evidence-Based Birth Instructor Program open today. We just hosted a Q&A last night all about the instructor program, and we have multiple live Q&A sessions coming up over the next few weeks. Just go to ebbirth.com/instructor to sign up for a live Q&A session if you're interested in learning more. So applications open today and they close September 5th. We have a lot of exciting things going on in that program. And if you're interested, I highly recommend that you attend a Q&A session or watch a replay of a Q&A session so that you understand more about the program and get a chance to ask questions. All right, that's it for this week's podcast. Thank you again so much for listening. And I'm excited that we're going to be moving on to a new series all about people who are creating change in their communities and helping bring evidence-based care to more families around the world. Thanks, everyone. Bye.